Why shoulder pain stops improving? You stretched it, you rested it, you might have even done physical therapy, and for a while, it actually worked. The pain came down. You started to feel like you were moving in the right direction. Then it came back. Same spot, same feeling, and nobody seemed to have a clear answer for why. That's not a failure of effort. That is not something you did wrong. What we're seeing more and more in the research is that when shoulder pain stalls like that, it's often because the body built a system to protect itself. And that system is now the thing keeping the pain alive. Shoulder pain causes everyone talks about. If you've looked into shoulder pain at all, you've come across the names everyone uses: rotator cuff tears, subacromial impingement, arthritis, poor posture from years of desk work, overuse, and referred pain coming from the neck. Every one of those is a real diagnosis. They show up on scans. They show up in textbooks. They are legitimate reasons why shoulders hurt. But here's what the research is starting to make clear. In a large number of chronic cases, those explanations are real, but incomplete. They tell you what's damaged. They don't always explain why it stays damaged. And there's one region of the body that plays a much bigger role in persistent shoulder pain than most evaluations ever look for. We're going to spend the next 15 minutes walking through exactly what that is and why it matters for your situation. The moment, the pattern, didn't make sense. A few years back, a patient came in, mid-50s, had been dealing with shoulder pain for about 8 months. She'd done the exercises. She'd backed off from activity. She'd even taken a real break from anything physical. And it helped. For about 3 weeks, the pain dropped noticeably. She felt like she was finally getting somewhere. Then it came back. Same location, same intensity. When the imaging was reviewed, the rotator cuff looked manageable. No dramatic tears, no major bone changes. Structurally, there was no obvious reason this shoulder shouldn't be getting better. But functionally, she couldn't lift her arm without discomfort. That gap between what the imaging showed and what the body was actually doing is what shifted the question. It wasn't just what's injured. It became, what is the body still doing to work around that injury? And that question led to a part of the system that almost nobody had looked at. What the research was actually trying to answer. Most explanations for shoulder pain are built around the injury itself, the tissue that's inflamed, the joint that's worn, the muscle that's strained. And that makes sense as a starting point. But the research we're going to discuss today wasn't asking what breaks. It was asking what happens after something breaks. Specifically, how the body reorganizes itself to keep functioning, and what happens when that reorganization becomes its own source of pain. Because in a meaningful number of cases, it's not the original injury that prevents recovery. It's the movement pattern the body built to avoid it. And that pattern doesn't show up on a standard scan. How this video is going to break it down. Here's what we're going to cover. First, we'll look at what the studies show when they compare different shoulder pain causes and track which ones resolve and which ones don't. Then, we'll explain the mechanism your body uses to protect an injured shoulder and why that mechanism eventually creates more problems than it solves. After that, we'll talk about the region of the spine that most shoulder treatments never evaluate and how its mobility directly affects whether your shoulder can heal. By the end, you'll have a clearer picture of why some approaches stall and what a more complete way of looking at this might include. What the studies show about shoulder pain. Shoulder pain is one of the most common musculoskeletal complaints in the world. Research consistently puts the prevalence somewhere around 16% of the general population at any given time, and it rises with age, peaking in the mid-50s to mid-60s. That's a significant number of people. Now, when researchers look at what causes shoulder pain, the usual categories hold up. Rotator cuff involvement is common, especially after age 50. Subacromial impingement, where soft tissue gets pinched in the space between the arm bone and the top of the shoulder, is one of the most frequently reported presentations. Arthritis contributes in older populations, and referred pain from the cervical spine, the neck, accounts for a notable portion of cases that get misattributed to the shoulder itself. All of that is well supported in the literature, but here is where it gets important. Studies that follow people over 6 months or longer find that roughly 40% of shoulder pain cases don't fully resolve within a year. And when researchers look at what separates the people who recover from the people who don't, it's often not about the severity of the tissue damage. It's about how the body is moving. The ones who stay stuck tend to share altered movement patterns, compensatory strategies the body adopted early on that never got corrected. The tissue may have healed enough to pass a basic test, but the system never relearned how to function without the workaround. So, the pain persists, not because something is still actively tearing, but because the body is still moving as if it is. When compensation becomes the problem. Research using electromyography, which measures muscle activity in real time, has confirmed what clinicians have observed for years. In people with chronic shoulder pain, particularly those with subacromial impingement, there is a consistent pattern. The upper trapezius is overactive. The lower trapezius and serratus anterior are underactive. That imbalance isn't random. It's a predictable consequence of the body trying to protect something. But here's the part that matters for recovery. That imbalance reinforces itself. The more the upper trapezius overworks, the more the lower trapezius and serratus anterior lose their role. The more those muscles lose their role, the more the upper trapezius has to compensate. It becomes a self-sustaining loop. A study tracking office workers with neck and shoulder pain found that people with this kind of compensatory pattern didn't improve with general stretching or strengthening alone. What changed outcomes was retraining the specific muscles that had gone quiet, teaching the serratus anterior and lower trapezius to activate again, while reducing the demand on the upper trapezius. When that retraining happened, pain scores dropped meaningfully over 10 weeks. When it didn't happen, the pattern continued, and so did the pain. This is why simply stretching a tight shoulder often doesn't resolve the problem. The tightness is not the cause. It's a symptom of a system that's been compensating for too long. When compensation becomes the problem. Research using electromyography, which measures muscle activity in real time, has confirmed what clinicians have observed for years. In people with chronic shoulder pain, particularly those with subacromial impingement, there is a consistent pattern. The upper trapezius is overactive. The lower trapezius and serratus anterior are underactive. That imbalance isn't random. It's a predictable consequence of the body trying to protect something. But here's the part that matters for recovery. That imbalance reinforces itself. The more the upper trapezius overworks, the more the lower trapezius and serratus anterior lose their role. The more those muscles lose their role, the more the upper trapezius has to compensate. It becomes a self-sustaining loop. A study tracking office workers with neck and shoulder pain found that people with this kind of compensatory pattern didn't improve with general stretching or strengthening alone. What changed outcomes was retraining the specific muscles that had gone quiet, teaching the serratus anterior and lower trapezius to activate again, while reducing the demand on the upper trapezius. When that retraining happened, pain scores dropped meaningfully over 10 weeks. When it didn't happen, the pattern continued, and so did the pain. This is why simply stretching a tight shoulder often doesn't resolve the problem. The tightness is not the cause. It's a symptom of a system that's been compensating for too long. The most important reframe. So, here's the reframe that changes how you think about this. The injury and the compensation are not the same problem. They feel like the same problem because they produce pain in the same area, but they require different responses. The injury needs time and protection. The compensation needs retraining and a different kind of input. Most early treatment addresses the injury well: rest, anti-inflammatories, basic range of motion work. But if nobody addresses the compensatory pattern, the pain doesn't go away when the tissue heals. It stays because the system is still moving as if the injury is active. And that distinction between where the pain lives and where the pain originates is one of the most important things to understand in chronic shoulder cases. Why recovery requires the right signal. Your nervous system adapts based on the information it receives. If you keep moving in a way that requires compensation, your brain learns to treat that movement as normal. It won't change the pattern just because you want it to. It changes when it receives consistent, safe, and specific input that demonstrates a better option is available. That's why recovery from chronic shoulder pain isn't just about waiting for the pain to stop. It's about giving the system a new signal, one that says it's safe to load this area differently. Stress, in this context, is information, the right kind of stress, controlled, progressive, appropriate to where the person actually is, tells the muscles when to fire and when to relax. It rebuilds timing, it restores coordination. But if the tissue is constantly irritated, if it's being loaded in ways that keep triggering the protective response, the nervous system stays in protection mode. And a system that's stuck in protection mode, it doesn't heal, it just keeps guarding. A supportive tool, not a solution. This is also where tools like scapular taping can sometimes play a role, but not as a fix. Research has shown that certain taping techniques can reduce upper trapezius activity in people with impingement symptoms. What that means practically is that taping may help offload the system temporarily, creating a window where the compensatory pattern isn't as dominant. Some people find that useful during the early stages of retraining. Others don't need it. It depends on how entrenched the compensation is and whether the person can tolerate normal loading during rehabilitation. It's a supportive option, not a solution on its own. The system. Most shoulder treatments ignore. Now we get to the part that most shoulder evaluations miss entirely. The thoracic spine, your mid-back. This is the region that research increasingly identifies as a significant and often overlooked contributor to persistent shoulder pain. Here's why it matters so much. Your shoulder blade doesn't move in isolation. It sits on your rib cage, and its ability to glide and rotate depends heavily on the mobility of the thoracic spine beneath it. Research has established that approximately 15 degrees of thoracic extension is required for full, pain-free overhead reach. If your mid-back can't extend or rotate adequately, your shoulder blade can't tilt the way it's designed to. And when the shoulder blade can't tilt properly, the space between your arm bone and the top of your shoulder, the subacromial space, gets narrower. That's the space where your rotator cuff tendons run. So now, every time you lift your arm, you're compressing tissue that shouldn't be compressed, not because the rotator cuff itself is the primary problem, but because the thoracic spine isn't giving the shoulder blade room to move. This is a concept in physical therapy research called regional interdependence, the idea that dysfunction in one area of the body can directly affect how a seemingly distant area functions. And when it comes to the thoracic spine and the shoulder, the evidence for that relationship is substantial. Studies comparing people with rotator cuff-related shoulder pain to pain-free controls have found significantly reduced thoracic rotation and extension in the symptomatic group. The difference is consistent across multiple studies. And here's the clinical implication. If you treat the shoulder without evaluating the thoracic spine, you may be addressing the symptom while leaving the mechanical restriction in place. When a different approach changes outcomes. When clinicians began incorporating thoracic spine assessment and treatment into shoulder care, the outcomes shifted. A systematic review of randomized controlled trials found that adding thoracic manual therapy, whether alone or combined with exercise, produced better results across pain, disability, range of motion, and patient satisfaction compared to exercise-based approaches on their own. One study reported an immediate 51% reduction in shoulder pain following thoracic and rib manipulation, along with a meaningful increase in range of motion. Another pilot study found that the combination of thoracic mobilization and extension exercise produced the largest improvement in shoulder pain and disability scores, significantly more than either intervention done in isolation. The pattern across the literature is consistent. Thoracic-focused interventions remain underused in standard shoulder treatment, in part because the connection between the mid-back and the shoulder isn't something most people think to look for. But when it's assessed and addressed, outcomes tend to improve in ways that shoulder-only treatment doesn't achieve. When you're ready for clarity. If you've been dealing with shoulder pain that hasn't responded the way you expected, and you want a clearer picture of what might actually be going on, that option is available to you. There is no pressure here, and no urgency, just the chance to get a thorough evaluation that looks at the whole picture, not just the joint. The contact information is on screen. Take whatever time you need. Your shoulder didn't become a problem overnight. It doesn't need to be resolved overnight either.